I'm going to be, in some ways, taking a slightly different tack. I think I'm going to be talking about HIV testing and its importance in this continuum, and really making a plug for the, I think, some social behavioral issues that we need to be attending to and thinking about, and the importance of community mobilization in our efforts. So, Wafa, that's your slide. You know that the Oxford Dictionary, the word of the year in 2013 was selfie. And I was thinking, as I put this, as you put it up, and I'm putting it up now, that certainly the word for the AIDS field in the last couple of years has got to be cascade. Leaky or not, cascade is something that we've all been talking about and thinking about. And our work really, that I'm going to talk about now in home-based counselling and testing and linkage to care, attempts to kind of address all of these issues, look at ways by which we can increase coverage of testing, improve linkage and initiation, and also achieve, levels of viral suppression. This is our study design. Community mobilization, as you can see, is a key component of that. We obtain consent in the households, consent individuals, take them through individual questionnaire, provide pre-test counselling, administer the HIV test. We use mobile phones as data collection tool, and for the HIV positives, provide counselling, provide point of care CD4, refer for CD4 and HIV care. We do viral load testing and follow-up visits. And this approach, which we've conducted in collaboration with the University of Washington, both in South Africa and Uganda, has allowed us to reach not the staggering numbers many of you have reached, but certainly test about under 20,000 people, achieve high testing coverage and excellent linkage to care in these two settings. This just gives you some indication, very briefly, of some of the questions we've tried to answer in these series of studies that we've done. In the pilot phases, really, we didn't know how this would work. Success in Uganda, pioneered there by our Ugandan PI, but we had no way of knowing how this would work in KZN. So some pilot work there in phase 2 for both sites, looking at the impact of our HBCT and linkage to care model on HIV infectiousness, risk behaviors, and stigma. And in phase 3, I haven't put that data up here, in phase 3, really just trying to tease out which of these elements of this model are effective. So looking at linkage more simple linkage strategies versus more intensive ones, as well as looking at different strategies for demand stimulation. I just show you here in the bottom some of the data for the pilot and the phase 2 studies. Linkages, enrollment is almost complete and still ongoing. And you can see some data that we're pretty happy with. Oh, sorry. And one more. Some data that we're pretty happy with. We've certainly learned from Uganda a high uptake of testing using this model. Improved in KZN, and certainly combined across the two sites in our phase 2 impact evaluation, high uptake of testing using home-based counselling and testing. We also show pretty good linkage to care. People at 6 months here, at 12 months here, 97% had linked to care. We also show 97% linked to care at 12 months. In terms of gender, which was the question that came up earlier on today, certainly the home-based counselling and testing model is a model that is predominantly favours women who are at home. And so we're finding, I think, similar to other studies, we're finding about 67%, both in our pilot studies and in phase 2, 67% of the women we're reaching are women. To the home-based counselling and testing model. And with respect to viral suppression amongst ART-eligible persons not on treatment, this increased from 18 to 61% at 12 months. This is the Kaplan-Meier curve to show you ART uptake by CD4 count among those not on antiretroviral treatment and enrollment. And I think it just shows and supports a point that Wafa was making in her presentation. You saw that there's quite a significant drop off from 97% who have linked to about 74% who enroll into care. And we asked people what that was about, and 74% of those persons who initiated ART by 12 months report the main reasons for not initiating ART include I was told, I was not eligible, and clinics also reporting repeating CD4 counts. So we provide the PEMA with obviously the CD4 count result, and people are often expected to repeat that. And so that the PEMA is really a kind of a step which you hope will decrease the number of visits and ease that burden that people face in dealing with the many steps at clinics in terms of linking, but often are asked to repeat that. We also found a trend, not shown here, but a trend towards higher ART initiation if tested as a couple. And pop heart, you don't have to breathe badly or terribly, horribly about that. I think I mentioned some of the issues around TTAMA, but I think we enroll people as individuals, but we encourage them to bring their partners in to test. And I think it works as well as would a much more traditional couples counseling approach. I think as we think about treatment as prevention, I think we need to think about much more expanded approaches and strategies for reaching couples. I think it's important, both if we're thinking about treatment as prevention in the HPTN 052 kind of approach, we really need to kind of identify partners and couples, encourage them to test and encourage them to disclose. But I think certainly in our context, we need a better understanding of partnerships and what this means. Now, the kind of model of couples used in Zambia, for example, the couples there are very different group. People get married, they seem to stay together for a long time. In South Africa, we have a range of partnerships. People who live together for a long time, people who are married, people with a range of partnerships, as our colleague from Zimbabwe was talking about earlier on. And so if we wanted to kind of find and identify these couples or these partners, I think we really need to do a bit more work trying to identify who these are so we can get to as many of those people who are at high risk and need to be tested, and need to be linked into care. And so again, the point's been made about strategies. If we're thinking about couples, we've got to find ways of finding and identifying men and linking them, and WAFA's made the points around that. But I think one of the things we have to think about as we think about trying to get partners and couples into HIV testing is we need to think about some of these softer issues that you biomedics don't think about. You think about them at home, but not in the context of this. And so as we think about treatment as prevention and hope that people would take this on because it's good for themselves and for their relationships, we have to kind of factor in the extent to which some of these other softer, murkier issues will influence their decision to do that. So things like, I'll do it because I want to preserve my relationship. I'll do it because of the level of intimacy and trust which exists in this particular relationship. And so often we are worried and concerned why people don't take up these great and wonderful things that we spend all of our efforts finding and proving work. And I think it's because of these kind of much more grayer issues that often do influence people's decisions to behave and to behave in particular kinds of ways. And similarly then, social, cultural, and economic issues, contexts are really, really important as we think about partnerships and couples. The issues of gender equality, anticipated stigma on the part of women who may not be able to always suggest that their partner test. So a couple of, I think 2 or 3 more slides, just some comments on some of the issues I think around testing we need to be considering when we think about treatment as prevention. I think it's pretty clear from all of the amazing presentations today that for us to achieve in TasP, we need to really get really high levels of testing coverage. I think what is also clear is that not one model fits all, not one strategy is going to allow us to reach the kind of coverage that we need. And so I think to reach the targets that we want, perhaps I'm talking post-implementation kind of phase, we need to be thinking about a range of these different models. And so, Diana, your hybrid model works well because you're looking at using both those campaigns, which will allow you probably to attract much more men, and the home-based counseling and testing allowing you to attract women and some of the other groups. So I think a hybrid, a combination approach is certainly the way to go to reach the kind of coverage we want and also to reach different target groups. I think we've shown today in a lot of your presentations that these community-based models are really fantastic and they really allow us to be responsive, to be nimble, to try and find people where they're located, and they don't always locate themselves 8 to 4 at a clinic and at a facility. They often are living their lives. But as we think about treatment as prevention, and as we move from, we've shifted the paradigm, and I think in many respects rightly so, but we've shifted the paradigm to testing for treatment. We test for treatment. That's really the primary purpose why we do this. And I think we do so at the expense of prevention. And we need to, I think, continue to think about some of these prevention issues in these much more briefer models, to think about how we're going to incorporate and include in them issues around risk compensation. We're talking about the need for frequent testing, so how do we address these repeat testers, this frequent testing? What do these models look like? Do we take people through the same kind of thing every time when they test every year? And so how do our counselling models also be nimble and responsive to this very changing kind of group that we are testing here by here through this approach? Diane was saying she didn't have enough time to make this point, and so perhaps it's worth me taking a minute to really iterate what I think is important. The time in our response to HIV and AIDS where we would, and I'm probably oversimplifying this, but I think our belief was if we found something and it worked, I can't hear that, can you hear anything? If we found something and it worked, people would come. I think those days are over. We know that we've got to do much more to get people to take up our interventions, no matter how effective they are. And in our experience, both in ACCEPT and both in home-based counselling and testing, this community mobilization piece is the bedrock on which all of those successes are built. It's critical and useful in thinking about and creating demand, in simplifying and reinforcing our messages, which we've talked about often today and yesterday, and certainly key in encouraging uptake and adherence. I want to just make a last and quick point about, I love diffusion of innovation theory. I mean, we use it as the core of Project ACCEPT, but it's something which I often think about. And I think we need to think about as we try and work on these really large trials, to really think about the way in which these innovations and these interventions are likely to unfold, and to try and better understand through behavioral and qualitative research some of these groups. Who are we targeting? What might be the motivators that drive people? Who might we be seeing first or early on in this process? And who are these kind of groups here, the laggards, the late majority, that are much more difficult to kind of reach? And as we think about these huge numbers that you have to do, to numbers of people you're wanting to reach, I think it's a useful thing as you process and think about this, is to kind of begin to understand and unpack who are these groups and who might you be reaching when, and what strategies you might want to implement to do so. When I put the slide up this morning, I was feeling a little like a lost sheep in a room full of biomedics. I always feel like a lost sheep in a room full of biomedics. So my tone when I typed it was a bit stronger than it is now. And I think it's because I've been largely very, I think, really encouraged by the way in which many of you have engaged, and I think are starting to talk that behavior is important language, which is wonderful to hear. And often as social scientists, you have to sit back and wait for the big men and women to say that, because when they say it, it is true, and it becomes a truth, and it's becoming a truth in your work, and I see that today. But I think we are at a critical juncture. We're motivated by our successes in HIV prevention in the last couple of years, but I think we're also challenged by some failures in voice and in MPrep. And I think it's really perhaps humbled us, I'd like to think. It's humbled us and reminded us that effective trial products don't equal automatic uptake. And I think part of that revisiting, part of that process is revisiting and expanding our assumptions about behavior change. And we think that people are rational, they're cognitive beings who act on information. And when they don't, we're surprised. And when we don't, we sometimes think that they lie. They're not telling us the truth. And I think people don't act, or people act because there's a whole range of other things that are going on in their lives, which we don't bother to understand because we really are interested in HIV only. And I think it's a reminder for us that HIV is primarily first, it's a dyadic event between two people. And whether or not we design product for a woman to take up for herself, the influence of a partner is there with her all the time, whether she asks him directly or not. What he wants and what he thinks is going to influence her behavior. And so addressing context and social behavioral factors, I think, is no longer a nice accompaniment to our real work of prevention and treatment. It's no longer beyond the remit and urgent, it's not beyond the remit and urgent time frame of our responses. We can't continue to use it as an excuse. We don't have time. We're doing this big and important work for that kind of stuff. Because I think the final and ultimate truth is, if any of the things we find to be effective in our trials are to be sustained, we really have to acknowledge way earlier, way much more before, that these things, these products, these vaccines, these tablets, these pills, these gels, these things are product of social structures, of relationships, of communities, and of families, and that ultimately is going to influence whether or not they're used.